Hello, today is Wednesday, May 17th, 2023. I'm Dan Hammermash. It's a pleasure having three experts on health and labor markets with me to talk about issues in health and labor markets. First is Carol Graham, who's a longtime researcher and currently acting director of the Economic Studies Division, I think it's called, at the Brookings Institution in Washington, D.C. Next, Chris Ruhm, who I've known, I think, since he started in economics in the late 80s, I believe, who's currently at the University of Virginia in Charlottesville. It's a wonderful place to be. And lastly, Meltem Daysal is currently at University of Copenhagen, I believe, after moving from the University of Southern Denmark, which is in Odense, I think. Anyway, these are all experts in health and labor markets. Let me just go with a couple of questions, one to each of them, and then some general questions. First of all, Carol, let me ask you, and this same question came up in an interview I had this morning with a German newspaper, interestingly enough. Does how happy we are affect how we do in the labor market? In other words, if I'm a happy person, am I going to be a more productive worker? What do you think?
There's plenty of evidence that says yes. But part of what we still are teasing out is the dimension of happiness, because sort of contentment isn't it. It really is sort of meaning, purpose, respect, and autonomy. And the reverse of it is what's going on in among prime age males out of the labor force in the U.S. today, as very much in despair, high levels of addiction, poor objective health, really poor mental health, and very vulnerable to the so-called deaths of despair. So, they've actually dropped out of the labor force because they've given up, right? I mean, they've given up on their lives. They're the opposite of happy workers. But there are all kinds of direction of causality problems, which I can speak to after. But that's a short enough answer, I suppose.
That causality issue, which of course all labor economists care about these days, as far as I can tell, is to me the crucial issue. The people you mentioned who dropped out, they dropped out because they were ineffective workers and weren't doing well and became unhappy, or were they unhappy and then dropped out? Which way does the causation go?
We don't really know. What we know triggered a wave of it. So sort of, I'm sure for specific cases, very unhappy people who are in deep depression are unlikely to perform well in the labor market, and things don't go well for them, they drop out. Or their mental health is so bad, they sort of have to. But on average, a lot of what triggered the whole wave of prime age labor force dropout, and estimates range as they're no longer the unemployment rate, but it's between 15% of prime and 20% of prime age males, even before COVID. This is a large amount of people. And one was a decline of the white working class, a decline of manufacturing jobs, mining jobs. And it was blue collar whites who had privileged access to those jobs. And thrown into the mix were opioids. And, the role of opioids is controversial on how much was the pharmaceutical company's fault. Whatever happened, it was a perfect storm of addiction and labor force dropout and actual real health problems, in terms of many of these former workers had physical health problems, but also psychological pain, right? And so they lost their sense of dignity, their purpose for living, their identity as workers, right? Women have an easier time because of multitasking and less problems when they get unemployed than men for that reason. But it really was the white men in the U.S. who are sort of the worst off group in that category.
And these are white men, presumably, are high school grads or maybe college dropouts, but certainly not college grads. These are less educated, right?
Overwhelmingly, they do not have a college degree.
Right.
Right. And, with a high school degree only in today's labor markets, not yesterday's, you just can't get anywhere. And the sad thing is, I've been doing interviews of low-income minority and low-income white adolescents, young adults in poor parts of Missouri. It's just sort of an exploratory thing. And it's the low-income white kids who have the least aspirations for college, the least hope for the future. Their parents don't support them in getting educated. So, we don't do something about it, we have another generation in despair.
Okay, one final question on this, which is totally speculative, but maybe you have a feel. Are these are probably 20 somethings, right? You're talking about disproportionately maybe 30s. Their political inclination is which way? Trump or no Trump, as it were?
Trump, for sure. And the other problem that adds to this that I've been working on more recently is that people in despair, just essentially defined as you don't care if you live or die, right? You have no anchor, you have no purpose, are much more vulnerable to misinformation because, you don't have anything else to anchor you. And so because of that, they're also more vulnerable to radicalization, conspiracy theories. And lastly, what we do know from like Alan Kruger's time use work with prime age males out of the labor force is they spend a disproportionate amount of time on the internet. So bingo, it's a perfect storm for vulnerability to misinformation and then the political outcomes of that.
Issue the best paper on this. You mentioned time use. That's half of my life, as you probably know. It's a wonderful paper by Kerwin Charles and Eric Hurst on this. Very detailed stuff on what these people do, 20-somethings without a college degree. Let me move on to Chris. I think, as I said, I've known you a long time. You are the go-to man on the effect of recessions on health. And you've always found, and this blew my mind when I first saw it, and I still find it difficult to comprehend, that recessions are good for people's health. Is that a fair interpretation? And if so, how can that be?
Yeah, so let me first say, we're talking about garden variety recessions here. Whole different story when we get into COVID, but we can talk about that. But there's a few reasons. I mean, one is a lot of things that go on with stronger economic activity are actually unhealthy. So things like higher pollution levels, more driving, which is a risky activity, people have less time. All of those can lead to actually worse health, worse physical health.
But mental health should presumably go the other way, shouldn't it? Or is that
and mental health generally does go the other way. Again, when we want to talk about COVID, that's a different story. But right, so in a typical recession, measures of physical health improve, but mental health. So if we look, for example, at suicides increase.
Now, what about, that goes back to Durkheim, of course.
Yeah.
What about
and Hammermesh, too.
And Hammermesh, that's not quite as original as Durkheim. What about stress, though? I mean, does stress go down in a recession because you're not working and not running around like crazy? Or which way does that go?
I think it's really hard to get good measures, like population-wide measures of stress. But what I think is true is when people used to talk about in bad times, people were more stressed out, but also work has its own set of stresses. And so, yeah, it's hard to know the net effect.
So the best thing is to have a job when everybody else is unemployed. The old Harry Truman definition of a recession. I'm employed and everybody else is not, as opposed to depression when I'm employed. Is that the best situation for me?
I'm actually not so sure about that. I think a lot of people, when the economy is doing badly, even if they have jobs, they actually get stressed about losing their job. So that's actually not so clear.
I wonder, given the tremendous rise in inequality in the U.S., which is to me one of the two salient features of the U.S. market in the last 30 years, do you think the effects of recession on health, mortality, have become less equal than they were, let's say, in the recessions in the mid-70s and the early 80s?
So that would certainly be reasonable to assume. I haven't actually seen good data on that. We were talking earlier about things like opioids, and it does appear that this relationship has weakened over time. And one of the reasons it's weakened is that drug deaths, which are primarily opioids, although now a lot of other things as well, definitely increase in bad economic times. And so that certainly could be related to the arguments you're just making about stress and inequality.
Can I just add really quickly to that?
Please do.
So one of the fentanyl, which is an opioid derivative, very, very lethal and much, much cheaper. and it's not a prescription drug, at least not as it's used. That's also changed the distribution of drug addiction and overdose deaths, as Chris hinted at. And so you get much more, before the deaths of despair, when Angus Deaton and Case first wrote about them, were considered sort of a white working class problem. And now it's very hard to understand all the dynamics, but older urban men now are their overdose rate has risen a lot. Actually, educated minority teens, the suicide rate is up.
Yeah.
It's gotten much more complicated. Chris probably knows more about the actual distributions than I do, but so I feel like a lot of what we found as patterns up until about 2017 have really changed.
Let me go in.
That's exactly right. And, part of talking about the whole deaths of despair argument as being sort of whites, particularly white males, that's much less true now, precisely because of what you're saying.
Let me go, Chris. I couldn't help. You gave me a wonderful lead saying it's all different now with COVID. So tell us about COVID and all this. We had a tremendous spike in unemployment. We're now back down to over full unemployment. What's happened?
Yeah. So when we look at deaths, pretty much none of the predictions that I made at the beginning of COVID held up. So one of the things I said is, okay, probably deaths are going to increase, but we do have this offsetting factor when the economy declines. And so maybe overall it won't be as bad as we expect. And in particular, probably the most consistent pattern we found historically is that in bad economic times, traffic deaths fall. All of that reversed in COVID. So traffic deaths went up.
Even traffic deaths, people aren't going to work. How could that be?
Well, as far as we can tell, what people were doing is there were fewer people on the roads, but those people who were on the roads were driving faster. They were driving in more risky ways, maybe under the influence. And then, of course, as traffic picked up, which it did fairly quickly, those habits didn't seem to change. So, yeah, we saw traffic deaths increasing.
Huh.
The other thing to point out is the economic effects of COVID were unprecedented in the sense that I don't think we've ever had as severe an economic downturn where people's personal finances actually improved, and in many cases improved quite dramatically. And I'm talking about in the US, at least, because of huge amounts of government support. So it was really an unusual situation in so many ways.
It's not just the government support. The people who kept their jobs had nothing to spend on. If you were a well-educated employed worker, we couldn't spend our money. I mean, just it helped share.
That's true. And you were, in many cases, also getting a check from the government in addition to that. But so you're right. If you looked at household finances, they improved quite dramatically. And yeah, I don't think we've ever seen anything like that when the economy, it didn't last for that long, but when the economy just crashed.
Yes. I've always told people, and I haven't seen this said enough, that our experience in the U.S. in the last 3 years is exactly the same as 1943 through 46. If you look at the history, everybody thought the economy in the U.S. would go down the tubes after the war, and they missed the fact there's this huge overhang of money waiting to be spent, which is why the economy boomed again. It's a fascinating business, and I guess what it says is it's hard to generalize from one recession to the next.
Yeah. And certainly when times are really different.
They are different. The problem is for economists, they're different all the time. Meltem, let me just go on to you. Mental health matters, right? We've talked about that. But, most important mental health to me is the mental health of my grandchildren are adults, but kids in their late primary grades or in high school. Does that matter more than you think in your own mind than for adults in the labor market? If you were to spend money to improve mental health, where would you put in your case, your Danish kroner?
I mean, I think then the interesting thing about mental health is that most mental health problems manifest themselves actually early in life. So about half of all mental health disorders are diagnosed before the age of 14. And the other interesting thing about mental health is that it has built-in persistence. So when we think about potential labor market outcomes, mental health disorders can affect individuals' life trajectories that contribute to labor market performance later on.
This gets toward the causative thing that Carol and I were talking about, really.
Yeah.
This starts that early. That's causation from health to labor market, right?
Yes. So, I mean, if you're asking me where I would put my money, I would definitely try to advocate for early intervention.
Okay. This seems very much like what economists are now following other people by about 30 years talking about. And then you put your money in education as early as possible and improve cognitive and non-cognitive skills early on. It's the same sort of thing. But it's mental health. What about physical health? Same. We already do physical health very well, don't we, on young kids in rich countries?
So we do well. And I mean, the thing is, so Janet Curry, starting with Janet Curry, I think a lot of scholars in economics now have consistently documented that mental health disorders like neurodevelopmental disorders, ADHD, and so on, have significant effects on educational attainment. And some of these effects are much larger than physical problems, like, asthma and injuries and so on and so forth. What we don't know much is that mental health disorders that manifest later in life. So things like depression, anxiety, conduct and behavioral problems. So there's less causal evidence on their effect on educational attainment and labor market outcomes later on. And I think that's where we're going to see a lot of work.
I have a question. This is a nasty old man question. I never heard the term ADHD until the 80s. Does that mean that nobody had it, or it's something we didn't really understand and still may have affected people when I was in first grade in 1949?
I think mental health is, obviously, we're just learning more. I don't see it particularly different than physical health. So if you look at the, international disease classifications, we also didn't have a classification code for RSV up until the 1994, 1995. But surely it existed before and it was there. We just know more about it these days. I do think that we're learning a lot more about mental health, and the classifications and symptoms and diagnosis codes are changing.
I've thought about this a lot. I thought about suicide, or not myself, but as an intellectual topic over the years. And I wanted in 2004 to do some work showing how the Bush recession had caused suicides to go up. I had done that during the 72 election, made the front page of the Wall Street Journal showing how Nixon had caused more deaths because of the recession. And I ran the regressions, and suicides had fallen like crazy because of happy pills, antidepressants. Has these pills been used to solve problems or reduce problems in young people? And has that affected the eventual success in the labor market? Or are we not just there yet?
So I think this is actually a really good question, because when we think about the effect of mental health disorders on, long run outcomes, identification, what we as economists call it, is much more complicated. There is the problem with diagnosis, there's problem with the timing of diagnosis, but I think there is a growing literature right now that really focuses on treatment patterns and how access to treatment affects outcomes. Some of my own work is in this area. And what we do find is that in Denmark, antidepressant treatments have economically large effects on children's ninth grade test scores.
Huh. Okay, so that does suggest.
Can I ask? Oh, sorry.
Sure, please do.
Just a follow-up question for Meltem. What's interesting, a lot of people in the U.S. say that the rise and increase in anxiety and depression among the young was a COVID-related phenomenon, and it's not true. And Chris knows this very well. It began as early as 2011, 2012, very gradual but steady increase in these traits among the young, or in these disorders among the young. And it's frighteningly coincidental with the onset of social media. I mean, the penetration of TikTok and Instagram and all these things, which having had teenagers at the time, I just can't believe they're good for your mental health or any health. But I'm just wondering if that is unique to the U.S. or if is that something that you find also in Europe or Denmark in particular.
So I think that's a little bit more problematic because in most of the cases, when there is a policy, that policy rolls out to the entire country. At least that's most of the times the case in Denmark. I do believe that there is some work that looks at the effects of rollout of internet in Norway, but I don't think they have looked at specifically at mental health outcomes. They have considered, just the typical socioeconomic status that we first think about. I think that's a good avenue to, expand research.
We've talked so much about mental health this whole time, and I call this a panel on health and labor markets. Does that mean we've moved beyond physical health and what really counts for labor markets is mental health? Or are we just going with the current flow of what people are interested in? Chris, what do you think, Carol, Meltem? It's not a question I gave you, but it's certainly suggested by what you all said.
I mean, I think both are important. I mean, I think one reason maybe mental health gets a lot of attention now is generally jobs have become less physically demanding. I mean, on average. And so if we're looking at changes over time, it's hard to make the argument that, it's kind of increased physical constraints that are a key factor. But with that said, I certainly do think that both physical and mental health play a role.
But I hadn't thought of your point about the fact that jobs are less physically requiring, that maybe physical health, ignoring the improvements that have occurred in physical health, is less important for jobs than mental health. That's a good point. I
think we're looking at trends, but I still think it's very important. Obviously, if you have serious physical health problems, that's going to have an impact.
Of course. Carol, any thoughts on that, or is Chris?
Yeah, absolutely. To add to Chris's point, that means if the trends in the labor markets lean more towards cognitively demanding tasks, people with mental health disorders have a harder time with those. They tend to be in lower end jobs in the labor market, so they're very likely to be displaced more than the average in the future, and don't even think about what AI will do. So that's one problem, which I think will, sort of highlight the role of mental health as well as physical health, obviously. And the other is that our mental health, I don't know whether we should call it crisis or whatever, the deaths of despair are now on a scale that they have wiped out about, the benefits that we made in dealing with diseases like heart disease, cancer, and others. And so the life expectancy gains that we made, with progress against those diseases have been reversed by self-imposed premature deaths. So it is, I think that it does heighten awareness of it.
If I could add one more thing, I think we want to be careful about making too much of a distinction between physical and mental health. They're closely linked. So, we have this, I think, largely unexplained increase in, perceived pain. And what is driving that? Is it, I think we know depression and pain are related to each other. We also know, in the attempts to market opioids to everybody, there's been a lot, an increased awareness of pain, and that could lead to actually, oh, am I in pain? Gee, I never thought about it. Yeah, I actually am. So, I think we want to be careful about making too sharp a distinction between them.
Fair enough. Let me ask a general question to all of you studying with Meltem. Okay, there's a famous quote in English: "If you have your health, you have everything." Is that correct?
Well, I would say that given the interrelated relationship between health and socioeconomic status, this statement is true, assuming one has access to resources to sustain good health. So, affordable healthcare, affordable education that teaches us the importance of health and good health behaviors and good nutrition and so on and so forth.
I remember looking at data 15 years ago or so, that people on Medicaid in the US were making more visits to doctors than higher income people who weren't eligible for Medicaid. I don't know if that's still true or not, but I bet it is. Why, given that all that doctor access, why aren't people in these lower income categories healthier physically, mentally as well? Chris, any thoughts on that?
Well, I think, a lot of that's reverse causation. They go to people on Medicaid. Of course, you could be on Medicaid, you could be on disability and on Medicaid, so you might have poor health to start with. The other thing is we know that although access to medical care is important, it's probably not the most important factor in your health. It's, it's genetics, it's lifestyles, it's behaviors. And so I think, that would be my answer.
Carol, any thoughts on if you have your health, you have everything?
Well, I think what we have in the US is people who have their health and have everything, and people who don't have good health and have very little. I think that's an outcome of our inequality. It's also an outcome of our really sort of divided up, scattered state, differentiated health safety net system. And so, the states that haven't rolled out the Affordable Care Act have less people on Medicaid and more poor people, whatever it is, whether it's safe, TANF or any support to needy families is, sort of always being taken away. And I just don't know how people who live on the edge in this country with a very precarious, job situation and a precarious benefit situation and families, often single parents with families, I just don't know how we expect that they'll hold it together. And so I think there come a lot of problems with that. Poor objective health, poor mental health, addiction, all sorts of other social problems.
You mentioned regional differences in the US, and for some of the listeners who are not Americans or Meltem, the degree of regional heterogeneity on these things is just remarkable because of a lot of non-federal programs. I look at New York. I was surprised to find New York State has the third highest longevity in the country, despite the reputation of the city being such a whole. It's actually very successful in mental and physical health. And I know my previous state, Texas, despite being fairly wealthy, is in the lower half of that. Politics matters tremendously in all these things. I'm missing anything. Go ahead.
Yeah, if I could add to that, I'm actually doing some work now, some more work trying to look at kind of deaths that occurred during the COVID epidemic and looking at the state level. And one of the things, it's exactly what you said, that there's such large differences, and trying to disentangle what's sort of just the health infrastructure in states. It turns out, as you said, some of the states that are doing the worst, they provide nothing. They're bad on every dimension you can name. And I'm talking about in terms of policy choices. So as Carol said, TANF support, have they expanded Medicaid? But also, average education levels are really low in those states. Now, some of that is exogenous. It's people don't move there who are educated. But a lot of it is just making choices about the kinds of infrastructure and supports for health that you have. And it's just striking how some of these states honestly just don't seem to care about the health of their populations.
I would have liked to
Except they try and make them have abortions. Same states.
Yes.
Make them have abortions?
Not make them, sorry, they prevent them from having abortions, make them have children. I thought that was a big typo or whatever it was.
Freudian slip. I would like to expand this to Europe. This is a very American focus on this question. And it would have been easier when Britain was part of Europe and was more like America. I don't see this heterogeneity across the EU. Is there some heterogeneity in these regards in the EU, or is it much more homogeneous than the United States? What do you think, Meltem?
I mean, in terms of like rules and regulations, I think things are much more homogeneous in terms of like protections. I mean, of course, there are exceptions like abortion issues. Poland, it's a big thing. We have our own issues in Europe as well. But I was just thinking about like the level of, these geographic heterogeneities you're talking about. And I mean, the extent of variation is surely not as large as in the US. But even in, smaller countries like Denmark, you do observe large heterogeneities, big, geographic differences in health outcomes, and also, provider behavior as well. So I think it's just a matter of the scale, but it exists, I think, everywhere.
Of course. You mentioned provider behavior. I wonder to what extent this is due to the different structure of the medical profession and the delivery of healthcare in the US versus the EU. Let me finish by asking, Carol, if you have any thoughts on this comparison across the Atlantic, or is this, I'm trying not to be too parochial here.
No, I mean, I would say there, as Meltem mentioned, there are some divisions, and I've been working with a guy in the EU Commission who works on something called NUTS 3, which are deprived regions within the US. It's a French acronym. And, they display some of the same traits that the regional disparities in the US sort of manifest themselves in more populist politics, all that kind of thing, a little more right-wing voting. But, like most other things, nowhere as extreme. And then, the UK has very big regional divisions, much more like ours. My colleague Fiona Hill's written very eloquently about them. But so I would say those things exist, but it's not as extreme, nor are the differences in regulations that Meltem referred to. I mean, in the US, it's really crazy, which is Chris was noting.
Right. Chris, any thoughts on that? Then Meltem will finish up. Chris?
I think what the other two have said, that would summarize my feelings. Yeah, I mean, we seem to have an extreme level of inequality in everything, including health and policies related to it. But, obviously, people are everywhere people are highly educated. Generally, people who are living in, the large cities tend to do better on these dimensions.
So maybe I should take a Pollyannish approach and say, thank goodness for the United States diversity. It allows economists to infer more things than would be true in Europe. Is that a fair statement? Meltem, what do you think? I'm being silly, I realize it. Why don't you finish up and say something
Well,
about this?
I'm tenured now, so I don't know. I guess, maybe lack of variation or lack of, heterogeneity here is pushing us to think a little bit more carefully about how to infer causality. So
it's a nice comeback to my comment. Look, let me thank all three of you, Carol Graham of Brookings, Chris Ruhm of the University of Virginia, Meltem Daysal of University of Copenhagen, Denmark. Thank you all for being with me today.
Thanks, Dan.
Thank you.
Take care.